This person is having, we have to give low dose maintenance ICS plus formoterol to this patient. And if the person chooses track 2, give him ICS LABA. Here you have the option. You can choose formoterol or salmeterol. Any drug, anything is okay. You can give any drug to this patient. The tracks are same now. If the patient has same symptoms like daily symptoms and waking up due to asthma more than once a week, and if you have done spirometry to this patient and the spirometry values are less, then choose step 4, give medium dose ICS plus formoterol. And in the track 2, give ICS plus LABA, anything you can choose. And if the patient has food control, we will be seeing what is good control, what is food control. If the patient is having these symptoms, daytime symptoms, nighttime symptoms, and the spirometry values are less, but he came to you and he said, my asthma is not under control, do something. Then you have to choose step 5. Here, you can give high dose ICS plus formoterol, you can add LAMA, tiotropium is the drug, and here we have to look for phenotypic assessment. Phenotypic assessment we have discussed now, where biologics play a great role here. The same thing is followed in the step 4. I told you by and large you can forget track 2, please follow track 1, that is better for the patient, beneficial for the patient. So we have discussed about low dose, high dose, medium dose, all these things. And these are all the inhaled corticosteroids that are available in the market. But most commonly available drugs are budesonide and fluticasone. So no confusion, just 2 drugs. And the low dose budesonide is more than 800. Fluticasone, low dose means 100 to 250. Moderate means and medium means 250 to 500. High means more than 500. We have given the prescription. That's not enough. You may not be knowing the technique properly. And there may be some people who will be saying don't use inhaler daily, it will damage your health. So you have to cover those up. We have discussed all that disease is not asthma. Many other conditions also present with these. So we have to make a proper diagnosis and we have to ask for the symptoms. This is another comorbidity and triggers. We have to look out for all these things. If we treat the patient with inhalers and everything and if we don't address risk factors and comorbid conditions, his asthma will not be controlled. We have to take and we have to review the response based on the symptoms, number of exacerbations, any side effects of the drug, and lung functions, how they are, whether it is improving or not, whether the patient is satisfied or not. We have to see whether the patient is taking the inhaler properly or not. He says, I am doing daily, I am taking inhaler daily, but his wife or husband says, no sir, she doesn't take. She forgets, whenever we remind, then only she takes. So we have to look at that situation. And the technique, some people get offended when you ask whether you are taking inhaler properly or not. They say, I will show you a video. Other things, triggers. If the patient is smoking and he is coming to you saying every time my asthma is not under control, you are not giving me proper medications, you have to ask whether you are smoking or not. If you smoke every day, you are sending air inside, smoke inside and asking your lungs to improve. That doesn't happen. So we have to see indoor and outdoor inflammation, damp walls are video. This is the most famous video. Description and assessing the asthma control and how to step down the medications and when we can stop medications of asthma. There is a most common question asked by many people when we can stop asthma medications. So we will go to cover these things in the next session. If there are any questions, I'll be afterwards.
Doctors make mistakes, and you try twice as hard to use your inhaler.
All the time, go through one a week.
Sure, you're right.
They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes, and you try twice as hard to use your inhaler.
All the time, go through one a week.
Sure, you're right.
Do I look like an idiot?
No. Why don't you show me how your inhaler looks?
sir. Now, next there is a brief. Dr. D. Srinivasan. Dr. Prabhakar sir. Dr. Ajay. Dr. Ajay, please hand over the bucket to Dr. Rajendra Prasad. These credit hours was done in a span of just 48 hours. Just 48. It is not possible. I always used to tell Dr. Srichalam is there, he left the hall. Whenever we do any work, please do it with credit hours. Your efforts, the one-day efforts and the certificate will have value. These are the days the state medical councils are emphasizing upon the credit hours, 6 credit hours per year. So this year, Nizamabad IMA has decided to give the 6 credit hours at your doorstep. In Nizamabad only we are giving 3 sessions for 3 days. This is the 2 hours. Today is over. Next in April month, again 16th April under the aegis of API and Dr. JTR, we are giving another 2 more session in April, 1-day workshop. And somewhere around in May, June, we will be going to have a 3rd session. So full 6 marks for this year medical council purpose for registration of your license. We are giving this thing. And for all this, the man who is responsible is our past chairman of State Medical Council, Dr. V. Ravindra Reddy. Please give him a big hand. But for his efforts, within 48 hours gap, these 2 credit hours would have not been ours. So, thank you. I have seen many stalwarts, Dr. Jaju Saab, after very long time, I have seen him attending such sessions. Thank you, sir. So these are the things. This is an index that how much weightage today's academic session has got. Thank you. Nandar Reddy sir, please give your valuable.
Dear friends, let me tell you, honestly, last 12 years I was the chairman, but I never encourage credit points. For simple reason, when you come to office, invariably you don't have credit points, and my staff will ask for something, and I'll get the call. So purposefully, me as a chairman of both the states and also Telangana, almost avoided it. Last year only we realized that we should be there. Now, when I was a chairman, credit points, the whole process will take 1 week to 10 days. And you have to apply 15 days in advance. 15 days in advance. Whereas Rajendra Prasad telephoned me, but I think the credit points was going up. Within 36 hours you will get your points. One person has to go apply. Then he will say, there are so many loopholes will be there. I was as a chairman, I know what are the loopholes, so we rectified them. And 36 hours, it is Rajendra Prasad was after me, Ramchandra was after me. So, the first time Nizamabad IMA is giving credit points. And for you to register, anybody is renewing registration after 2024, January, 1st January 2024, you are going for renewal, you have to have minimum 6 credit points. Every year 6 points, 5 years 30 points. Not necessarily, after 5 years, suppose if you are going after 4 years, you should have 24 points. So like that, Hyderabad City Branch IMA is taking this credit points this long time. They conduct regular CME, but CME should be 4 hours. It cannot be a 1 hour CME and ask for credit points. CME means 4 hours minimum. Then only you will get 1 point. So I think most of the CMEs in Nizamabad, whether it is IMA Armour, IMA Nizamabad, Foxy, API, IAP, we can try for credit points because that is how some of you made go to conferences, special conferences, but for those who are not going to attending regularly, IMA or the other faculties will give the credit points. And with these few words, and I really congratulate Dr. Rajendra Prasad, man who had done it single-handedly and a wonderful CME. and my dear friends have been practicing for the last 42 years as a pediatrician. When it comes to asthma, I always love to read acute severe asthma many times. When it comes to chronic asthma, I skip the page because there so many combinations are there. I said, why get to the the only two we will advise, but I used to advise mostly the salbutamol. Now you say it's mostly the other way around. I mean, this chapter is something we heard by the end of the day when you go, we get, I think the speakers are simplifying it, and I request Rajendra Prasad, like Ramchandra also told, why don't we have a presentation, the same presentation on YouTube? I think this can be done, it will be useful. Asthma is a regular topic, most of the patients, some of them claim with asthma specialists, and it is a disease which everybody should all be aware. So with these few words, I thank the organizers for giving this opportunity. I congratulate the IIM Nizamabad for getting the great points and hope it will be continuing for all the CMs. Thank you.
We have got so many specialists and super specialists in Zamba. So we are planning to upload the latest recent updates onto the IMA YouTube. We will shortly IMA YouTube and all the updates and recent updates and what are the challenges, what are the threats. So these are the things that are going to be there in IMA YouTube. Thank you, Dr. Ramohan Rosa, for so much keen interest at 8 years of age. He has taken part in the CMU. Please give him a big hand. And thank Gattan Sahib is also very rare these days. Gattan Sahib and Shankar sir. After a long time I am seeing Shankar sir, Ramakrishna sir, and Ram Mohan and Arvind, very rare personalities. Thank you very much for coming to the CMU. Thank you. I am sorry if I have forgotten any known faces to me. Srihari Narayana.
Request Ravindra Reddy sir, please hand out the memento to Dr. Vijay Kumar sir. And our beloved Arku doctors also please join. Beloved Arku doctors please join. Yes sir, join. Both the doctors will arrive na? Now I request Dr. Ramchandra. Even with the busy schedule also, so RP made it possible today. So almost he is disturbing Ramchandra sir and me for the last 10 to 15 days. Meeting. Previously worked as a faculty in Nellore, Narayana Medical College, now Assistant Professor of General Medicine, native of Nizamabad only, and Dr. Raj Kamal Gaur. So he is also a physician and he recently started Sukhi Baba Hospital with Dr. Bhaskar Reddy. So now to Dr. Shankar sir also.
Case scenarios to asthma management. In the previous session, we have discussed what are the changes in the GINA guidelines and what are the tracks of treatment, how to select treatment according to the steps. So we will discuss a case scenario, and based on that we will see how to manage a case of asthma. I will read out the case. It is 4 times a month. He also experiences chest tightness. Symptoms are relieved spontaneously after he rests for a while. No nighttime awakenings. So this is a common scenario that we see in the general practice, where a child had asthma in childhood, but he has outgrown it in adolescence, but asthma resurfaces in adulthood again. So that has caused the asthma. Recently, he has shifted to a room, and his room has this fungus on one corner of the room. Fungal spores are one of the reasons for exacerbation of asthma or new symptoms of asthma, because they are triggers, allergens as well. And he had a roommate who is a smoker. Smoking is also one of the triggers for asthma. So these are the reasons why he had asthma now. And when his spirometry was done, his FE1 by FPC was 72%. That means it's good. FPC is 108% predicted. That is also normal. FE1 is 78% predicted. This indicates that his spirometry is almost normal. So he has no disturbance in the spirometry. The next awakenings, and the spirometry is also good. And he has some triggers which has started his asthma again. So which drug we have to choose, and which step of the treatment we have to start him on. Low symptoms. So we coming to GINA track-wise treatment. Track 1, track 2. Track 1 is a preferred track, track 2 is the alternate track. And this man, he had low symptoms. So obviously we have to go for step 1 and step 2, less than 4 to 5 days a week. So we have to give him SOS, ICS plus formoterol according to track 1. And according to track 2, we have to start him on low dose maintenance ICS and relievers if needed. Right? So how we have to write the prescription for symptoms? Because he is not having regular symptoms, no nighttime awakenings. So SOS only we give him. And we have to explain him how to use the inhaler properly. If it is a breath actuating inhaler, if it is the inhaler, he has to gargle and rinse his mouth. We have to tell this for sure. If they don't wash their mouth, if they don't do gargling, they will develop some disturbance in the throat. Sometimes people may develop candidiasis also if they are immunosuppressive. So definitely we have to tell them to wash mouth. And we have to tell the patient to avoid the triggers. If you don't avoid the triggers, definitely you will have regular symptoms. Avoid exposure to tobacco smoke, avoid exposure to fungal spores. And we have to ask him to come after 1 week of the prescription. This is according to track 1. And in case of exacerbations, if SOS, he can take this ICS plus lavasane inhaler. If we choose the track 2, then we can give him low dose inhaled corticosteroid, budesonide 100 micrograms, 1 puff twice a day. And in case of exacerbation, we can give SABA plus ICS SOS. If the patient has any symptoms and exposure to triggers. And if the patient prefers spacer instead of breath actuating inhaler, then we have to explain him how to take the medication through spacer plus inhaler. Because the steps are different for each type of device. It has to be explained clearly, stepwise, and ask. We have to tell them that they have to wash the spacer regularly. If they don't wash it, the electrostatic forces that are there in the spacer will be lost, and proper delivery of the drug is disturbed. And he has to avoid exposure to smoke as well as fungal spores, and we have to ask him to come after 1 week. So why we are asking them to come after 1 week only? Because they are not professionals. Definitely they will have some confusion in taking inhaler. If they are doing any mistakes in taking inhaler, we can correct them as early as possible before he loses confidence on the inhaler devices. Because if he uses for long term and if he is not using properly, he may feel that I am using inhaler daily but my symptoms are not controlled. So to avoid that, it is better to come as early as possible. And as we have discussed, Some people, like surrounding people, doctors surrounding their homes, many people will be there. They will be giving free advices. Don't use inhaler, it will become a habit. Don't use inhaler, they contain steroids. They tell these all things to them. If they have any such kind of things in their mind, we have to make them clear that these are not right. Nothing is correct because inhaler use is very much safe. Inhaled corticosteroids contains only very low dose, microgram dosage, so it is not at all harmful. We have to clear the doubts. And the most important thing is he has to change the room because he has fungal spots in one of the corner that may cause serious exacerbations in the future. Either he has to change the roommate or his roommate has to stop smoking. Otherwise, he will be smoking, he will be having exacerbations. So, after knowing about the triggers, we have to know something about what are the other common triggers that are present in the environment. Pollen, bugs in the home like dust mites, cockroaches, mosquitoes sometimes, ants, these are all triggers. Chemical fumes, cold air, fungal spores, dust, smoke, strong odors. Most of the people present to us after washing bathrooms because of the acid smell. They commit severe exacerbation. So these things has to be, we have to explain them to avoid these things. Pollution, indoor and outdoor, anger, we generally miss. It is one of the reasons. Emotions, stress, these are also other reasons for exacerbations. There are triggers of asthma. Pets, some people, if they have pets at home and if we ask them to keep the pet away, your wife is having asthma, she is having frequent exacerbations, keep the pet away from you, leave the pets away. Some people say, either I will divorce my wife but I don't leave my pet. Some people are so much addicted to their pets. Such kind of situations are also there. So we have to explain the importance that pets are not good at home. Because as started before, dander, hail are thought as triggers, but actually saliva is the main reason. They say that no sir, my dog stays outside, I don't allow it to come to my home or bed or anything. But actually the saliva, that will cause exacerbation. It becomes a dry droplet, it will become an aerosol, it will mix up with the dust, and when he inhales, it goes inside and causes triggers. Even if children are having asthma symptoms, we have to ask the teacher. They may say that we don't have any pets at home, but the teacher may have pets at home. He carries them on his clothes and that will be dispersed in the classroom because of the fan. These things also do happen. So we have to take meticulous history when we talk about triggers. So that's how we have to treat the patient. Let's discuss about another case scenario. Here we have a patient, Mr. Kiran, a 30-year-old bus driver. He is a known case of asthma. He takes inhaled salbutamol DPI SOS whenever he has symptoms. Now comes to us with complaints of feeling breathlessness 3 times in the last 2 weeks, for which he took his salbutamol inhaler. He also woken up due to his symptoms once. He also has runny nose and sneezing since last 1 month. He has been visiting doctors who have prescribed him some tablets and steam inhalation. Our examination is comfortable, vitals are stable, bilateral wheeze is present, saturation is normal, chest X-ray is normal. And this is one thing, because most of the times when a patient with exacerbation symptoms of cough and fever comes and we do X-ray and X-ray looks normal. And patient feels that he has no disease at all. His X-ray is normal, no survival is said. Why you are saying that I have some problem? Why my symptoms are not subsiding? This is asthma, because asthma we cannot diagnose by X-ray or CT scan. It means pyrometry obviously. And FEV1 is 65% in this person, and his bronchodilator reversibility is 240 ml and 14%. That means he has moderate obstruction with a good bronchodilator reversibility. So now we have discussed the tracks of treatment. Which track we have to choose and which step we have to start to mark. So according to GINA guidelines, he is waking up due to asthma. His pyrometry function is also low. So he falls in step 4 of asthma. And we have to give ICS, medium dose ICS plus formoterol to this patient. So this is how we have to write a prescription. We have to write the inhaler and how many puffs he has to take daily. And in case of exacerbation, he has to take the same inhaler. If he is spacer, we have to explain him how to take the spacer and how to wash it. And he have to gargle also. And he has to avoid exposure to pollution because he's a bus driver. And we have to ask him to come after 1 day. Okay? This patient came after 1 month. His symptoms are not fully relieved. He still has some breathlessness despite of optimal treatment, good adherence and good technique. He is following everything, but his symptoms are not under control. That means we are missing something. So what it means is we have to look for that. And he is saying that his symptoms are not controlled. We have to see why it is not controlled. For that we have to ask 4 questions. Whether any daytime asthma symptoms more than twice a week, any night waking due to asthma, any need of use of SABA more than twice a week, any activity limitation due to asthma. Suppose if a patient says that he is unable to go to school. I mean, children most commonly we see they don't go to school because they feel uncomfortable or they cannot explain properly. They say that I don't go to school today, they cry, they may vomit, they may cough, these things may be there. That is limitation, activity limitation. Any missed office work or any missed job or any missed trips also. He might have planned to Maldives, but because of his asthma, he is fear of going by flight. So that is also one reason. So that also can be taken. If none of these are present, it is well controlled asthma. If 1 or 2 is present, it is partly controlled asthma. If 3 to 4 of these are present, it is uncontrolled asthma. Now we have known that it is an uncontrolled asthma. What is the reason? We have to look for this. This is more important actually. In the morning session, Vinod sir also said, and even Dr. Shura sir said, and by phone call when I spoke to Dr. Babaredi sir, sir also said this is very much seen in clinical practice, and we are discussing in the morning. Allergic rhinitis, asthma, these are all one airway. So we cannot miss allergic rhinitis in our practice. Because if we don't address allergic rhinitis, asthma will not be controlled. It is one of the most common comorbid condition leading to poor control of asthma. A large study was done in 2022. A large number of children and adults. It was seen that almost 25% of adolescent population in India suffers from allergic rhinitis, and one third of them have ocular symptoms also. Most of the patients, actually after reading this article, I am asking them, do you have itching of eyes? Almost all asthma patients, at least 20 to 30% of people, they say, yes, I do rub my eyes, I regularly rub my eyes. These things are seen. Even for allergy, we have to ask all questions, urticarias, angioedemas. When I started this, they have mild angioedema, mild symptom, they may recover of it by some time because of the body's response. But if they are exposed to the same allergen again, they may have a severe reaction in the future. So we have to look and ask these organs, and we have to address these organs. 1 out of every adult suffer from allergic rhinitis, and almost 40% of asthmatics have allergic rhinitis. AR is underdiagnosed and poorly treated in India. Coexisting and poorly treated AR is a very important reason for uncontrolled asthma and need for nebulization medications. Hence, it is very much important to diagnose and treat AR correctly. How do we ask him? We should ask him whether you have rhinorrhea, sneezing, itchy eyes, on exposure to house dust, pollen, animal dander, saliva, fungal spores, insects, and occupational allergens. If any of these are present, then we have to classify the allergic rhinitis based on the symptoms like intermittent AR or persistent AR. And after that, we have to classify them as mild, moderate, and severe. Intermittent means if the symptoms are present for less than 4 days a week or for less than 4 consecutive weeks. Persistent AR means symptoms more than 4 days a week and for more than 4 consecutive weeks. Based on that, we have to ask some other questions like, do you have any sleep disturbances, impairment of daily activities and leisure or sport, no impairment of school or work, and symptoms present but not troublesome. If these things are there, if no disturbances are there, then it is mild. If these are all there, then it's moderate or severe allergic rhinitis. So we have to treat allergic rhinitis also. If it is mild intermittent, we have to give only antihistamines. If it is mild persistent, give intranasal steroids or antihistamines. And we have to review the patient after 2 to 4 weeks. If it is failure, then we have to step up the treatment. If it is moderate to severe intermittent allergic rhinitis, give resistant air, give intranasal steroids, and review after 2 to 4 weeks. If failure, step up. If improve, continue for 1 month in all cases. If they doesn't improve, give antihistamine. Again, we can add montelukast also. But regular use of montelukast and antihistamines is not advised because they are associated with cognitive disturbances, psychological disturbances also. So better to avoid giving more. Sometimes what happens is patients insist us that to write medications, tablets only. They don't want to take inhalers because of the taboo that is there in the society. They want only medication. So some people take only montelukast and levocetirizine. They feel comfortable, but in the long run, the inflammation that is there inside the airways or the air mucosa, that will causes disturbances leading to remodeling and permanent persistent changes. After knowing about allergic rhinitis, we have the other most common comorbid conditions leading to poor control of asthma, GERD, and obesity. GERD is one of the main reasons for difficult to control asthma. We miss generally these things. But patients may typically say that their symptoms are asthmatics are more after taking food, and it is followed by heartburn and reflux. If these kind of symptoms are there, we have to think about GERD. And if the patient has postprandial coughing, maximum 10 minutes post-meal, that also suggests that GERD is one of the reasons, especially in the children. Sometimes they will cough and they will vomit also after taking food. If they have these symptoms, we have to think of GERD and we have to address it. If the patient has nocturnal cough, wheezing, vomitings, more often after lying down, then GERD has to be corrected. It is very simple. You all know this. We have to do PPS and lifestyle modifications. Give the drug at least for 3 months, and if we treat GERD, asthma symptoms will definitely reduce. It may not reduce the function, the pulmonary function, but symptoms will reduce. So the most commonly known comorbid conditions are GERD, AR, atopic allergy, vocal cord dysfunction, smoking, and COPD. And newer comorbid conditions also emerged recently, like obesity, metabolic syndrome, diabetes also. It is associated with increased asthma attacks. Mental disease, psychological problems, Ravikant sir was discussing in the morning. These things are also associated with asthma attacks. And cardiovascular diseases are also recently been understood that there are also reasons for cardiac attacks. Even cardiac asthma is one kind of condition, one type of condition where we see these. If they have similar symptoms continuously, they may develop asthma also in the future. So coming back to the patient, we started him on fluticasone chloride nasal spray once between each nostril twice a day. And he was improved, but when we should ask the patient to come back for review, and when we can expect the patient to respond to the medications. These are the questions that come to our mind and patient asks us regularly. We have to continue the medications for at least 3 months. Most of the people, if they feel comfortable, if the symptoms are relieved, they insist on stopping medication, or they themselves, we may consider to step down the treatment. But if the patient has any forcing exacerbation risk, like if the patient is going to have exams in the future after 3 months or after 1 month or 15 days, better not to step down the treatment, because stress also can induce asthma. It can exacerbate asthma. So we shouldn't reduce the dose at that point of time. We have to ask the patient to continue the medication till the exams are over. If there are any such patient festivals like Diwali or Holi are there will be risk of exposure to the smoke, dust and everything. So we cannot reduce the doses at that time. We have to ask him to wait for some more time, and after the festival is over, if the patient's symptoms are well controlled, we have to reduce the dosage by 30-50%. If he is taking 400 micrograms of inhaled corticosteroid, reduce it to 200 micrograms. Do not change LABA. If he is on 6 micrograms of LABA, continue the LABA, but reduce the ICS dosage by 50% and ask him to continue the same medications for 3 months. If his symptoms are controlled, then we can reduce the doses further. And if it is a low dose, if he has come to step 1 of asthma from step 4, and if he is on step 1, no symptoms, no exacerbations, nothing, then you can consider to change the medication to OD and SOS if needed. This is the next common question asked by all patients: when I can stop the medications? So, as we discussed, we have come to step 1, and no sex inhibitions, no requirement of SOS medications. We may consider to stop the medications. But if there are any forcing conditions like festivals and anything, exposure stress, then better ask them to continue the medications. But we have to explain them that asthma is a genetic predisposing condition. So, though his symptoms might have subsided but this time, but he may have future exacerbations or exposure to environmental triggers or stress. So, with this, I conclude my case scenarios and session. If there are any questions,
currently having these triggering issues, number one. And number two, there are 2-3 other concerns, especially after the COVID. If you see in our day-to-day routine OPD practices, the allergic rhinitis cases have raised significantly, especially after the COVID. From the analysis out of 30 OPD who are suffering with allergic rhinitis, we have noticed 2 to 3 having fungal sinusitis and all the fungal picture. That's also one of the most. The main concern is previously is the same body, now also the same body.
so CKDs, vaccination should be addressed to all these patients because now we are seeing so many influenza cases. So it is better to give influenza vaccine to everyone every year. You have to motivate them to take influenza vaccinations. And Prevnar 13, and after 3 months Prevnar 23, pneumococcal vaccines. We generally advise to all these patients, especially patients who are having uncontrolled asthma, vaccinations are very much important. Coming to the very good question, the next question, post-COVID, we are seeing so many patients with increased asthma symptoms, allergic rhinitis symptoms, allergy symptoms. Why this has happened? Because it is really needs a research also, and there are some practical things also to explain this. There will be a switchover of this TH2 TH1 thing happens in these patients. So what happens is inflammation that is there, that activates and it will change to TH2. This causes risk of, they may develop these asthma symptoms, exacerbations, increase the patients with, in the morning session also Dr. Bharata has highlighted TOAD, tuberculosis associated obstructive airway disease. The patient has tuberculosis, before that he never had obstructive airway disease because of the switchover of the inflammation that is taking place inside the body. And patients are actually, we haven't seen how the IgE levels in these patients, but it needs a research. But something is happening in them and the inflammation is increasing and that is causing hyperreactivity of the airways. They are landing up in asthma or allergic rhinitis. They are presenting with these symptoms. Yes. Definitely to accept it. Anything to add to this?
They developed what commonly called as wheeze-associated lower respiratory tract infection, and then eventually they may become asthmatics in the future. So for this, there is a pipeline vaccine that is awaited. Probably we may expect the pipeline vaccine for RSV in next couple of years to India. I think this year we are getting approved by FDA. So probably by 2025-26 we may get a RSV vaccine. So probably vaccinating all the children for particularly below 2 years.
Discussing with someone over lunch also. One, as you pointed out, there is a role of the basic immunity which is being hampered. And secondly, now there is studies or research being going on where the COVID virus has something to do with your nasal epithelium. So that research is also going on, hence maybe after COVID, especially after the so-called third wave, there are a lot of, as Sir said, allergic rhinitis cases. The function of the parenchyma otherwise is normal, but this hopefully maybe another year we will have exactly. But do vaccinate your patients for the flu and the pneumococcal one. Please take home your gear and do vaccinate all the patients.
We could also have some more highlights regarding so that we together we can more patients so that we can
Then
out of 10 patients we
डॉक्टर साहब पिछले साल क्या इंजेक्शन किया था वापस है. Believe me. So if you insist them and if you give it to them, then the complaint slowly going to increase. COVID has done the tapping thing about vaccination. Now for COPD, 5 vaccines are compulsory recommended in our guideline: the COVID, influenza, pneumococcal, DPT booster and the varicella. So we have to give, we should recommend slowly the acceptance.
Another important component which is a silent epidemic that is going on is post-COVID. There's a lot of reflex issues that we are seeing in practice. GERD, all the cough is not because of asthma or cough variant bronchial asthma. Please underline this statement. So we have seen, we have done close to in the past 2.5 years, 3,000 documented cases of endoscopy for various respiratory complaints like cough, breathing difficulty, where the pulmonary function tests are, if we do probably mild restrictive lung disease, there is no hyperreactive component. So in these patients, when we evaluate for breathlessness and then cough, the H. pylori is the culprit. So please make sure that we address this H. pylori. And then H. pylori intense inflammation is causing a lot of reflux, and then that increases the micro aspirations to the lung, and that is causing the dyspnea and cough in these patients. So I think this is another point which we have seen. This is an unpublished data, but we have documented close to around 3,000 cases.
Dr. Srihari Narayana sir, to honor Raj Kamal sir.
Will understand practically how to manage it. Address these 5 key points. We have done our job in management of COPD. So generally, lot of complications. They will be left over with oral salbutamol, theophylline, neoastellin, terifilin, epiphylline, these kind of bronchodilators. On and off, very pathetic situation, particularly in India, is antibiotics will be available rampantly. Once we give a good prescription, that prescription goes on for years together, and then once they don't respond to this prescription, they will come back again. This happens both in asthma and then COPD as well. Asthma particularly, we do see patients coming from probably 10 years back. We have someone would have written Aerocard. That Aerocard will be going on. So what are the various goals in management of COPD? So first and foremost is, it is very important to implement therapy protocols where the mortality and morbidity of the patient should be addressed first. Mortality should be decreased and morbidity should be decreased. So what medications if we add or what measures if we suggest, the patient disease can be at least halted. More importantly, quality of life. His quality of life can be made better, improves endurance levels, improve overall health status by addressing the comorbids, and if we can manage the prevention part of exacerbations, because it is very importantly we should understand, one COPD patient if gets admitted into ICU, the chance of having a recurrent admission in the next 1 year is at least 2 times he is going to admit into the ICU. And the chance of losing this patient once he reaches ICU with a type 2 or type 1 respiratory failure is close to 50%. So the mortality rate at the end of 1 year for a COPD exacerbation, if we can prevent an exacerbation, then we have addressed our primary goal. And identify the complications and then treat it accordingly. So coming to disease progression prevention, as I was, the morning also I was mentioning very clearly, we assume smoking as the most important cause of COPD, but it is not so. In Indian subcontinent, again addressing, please make sure the biomass fuel exposure, air traffic pollution, lot of exposed to dust, and Dr. R.P. was clearly mentioning, exposed to a mosquito coil exposure, single coil leads to roughly around 100 cigarette smoke. So that means these are all the various things, okay, and which are the cause of COPD in India. So coming to, I'll show you. So how to cut down the exposure to such things. So we have to, if feasible, have a chimney or an exhaust fan and try to use low smoke chullas, replace the biomass with the LPGs, and wherever it is feasible, electric stoves and solar stoves can be implemented. So other important measures where we can replace mosquito coil and the all-outs is, okay, using the nets. That is, if we can do this, probably the indoor air pollution can be cut down to the minimum, and then the amount of COPD burden, at least couple of decades from now, we can decrease. And symptomatic management. So the chief complaints what we see is breathlessness and then cough. So what are the drugs that we need to add, and what is the line of assessment? If we see the line of assessment, it is a simple score, okay, which can be practiced or which can be, we can hand over to our physician assistant to document the COPD assessment test before they enter into our OPD itself. So where they assess what is the chance of having a cough, chest tightness, amount of mucus production, what is the level of tolerance to the work and efforts. So these are the things that that comes in the CAT assessment score, and it plays a very, very important role in designing the treatment of patients. And we have understood by now that spirometry is the gold standard for diagnosis of COPD, and for assessment of dyspnea, we use MMRC and then CAT assessment. And what is the line of management? As clearly mentioning, so even Bharat was mentioning, Dr. Bharat was mentioning, so from legal point of view as well, and almost in 2012-2013, we have heard a case from my colleague Dr. Bolimeni Srinivas from Dallas, that prescription of ICS-LABA, that means their Acuhelus ceritide, which is one of the standard medications, salmeterol plus fluticasone for COPD. Okay, the insurance authorities have denied the insurance approval, because for a COPD patient, the choice whenever he is not in exacerbation and whenever the MMRC is reasonably good, the choice is LAMA. It is not LABA plus ICS. And in 2023, it is clearly the recent board guidelines said very clearly, LABA plus ICS has got no role in management of COPD. So coming to, patient who have minimal symptoms, then you can start on a bronchodilator, preferably LAMA. And then patient who had an exacerbation in the previous 1 year, or at least 2 exacerbations in the previous 1 year, or at least 1 exacerbation that led to hospitalization. So these kind of patients, it is advised to start on, to begin with, those who have had an exacerbation, start on triple therapy and then come down and then de-escalate to LABA plus LAMA management. So for asthma, the treatment of choice is, we know, inhaled corticosteroids, and then the next level is inhaled corticosteroids plus LABA, and the next level is higher dose of inhaled corticosteroids plus LABA. Whereas COPD, the choice is LAMA, and the next level of choice is LAMA plus LABA, and the next level is LAMA plus LABA plus ICS. But I was about to ask that Dr. RP the same question. Even in asthma, if there is a significant remodeling and the patient is exhibiting severe COPD changes, so please understand, if you are treating COPD and there is no clear-cut asthma component in this, then don't put them on ICS plus LABA. This is a management of COPD. The evidence says, and even GOLD guidelines recommend, when there is a history of hospitalization or hospitalizations for COPD exacerbation, those are the patients a strong indication for addition of inhaled corticosteroid. And if their blood eosinophil levels is more than 300, again please consider they respond better to inhaled corticosteroids. If there is an APO component, asthma COPD overlap, there is no doubt we can add comfortably inhaled corticosteroids. And the lesser evidence is for if there is only one moderate exacerbation but he doesn't need any admission. These kind of patients you can better manage with LABA plus LAMA, and if patient is not responding, you can step up to inhaled corticosteroids. And the eosinophil levels are borderline, 100 to 300. And in which patients we are not supposed to add inhaled corticosteroids? Those patients who have had recurrent pneumonia, if the blood eosinophil levels are certainly less than 100 and history of either tuberculosis or atypical tuberculosis infection, and other CD4 inhibitors, and the evidence says it increases the lung function and reduces exacerbation. It has got a direct bronchodilator action and also anti-inflammatory action. And we commonly see, one of the comments from peripheral doctors and then those doctors who doesn't understand role of macrolides in therapy. Particularly azithromycin, there is a wonderful paper which was published in American Thoracic Society journals, that is Blue Journal, AJRCCM. So, where long-term azithromycin for maybe couple of years as well has got role in reduction of exacerbation, thereby prevention of admissions into the ICU and thereby prolonging the quality of life and decreasing the morbidity and mortality as well. So, I have very good number of patients who got stabilized, who were on LABA-LAMA ICS, despite that patient is not improving, and then patient receiving epiphyllin, roflumilast, not getting better. These kind of patients, azithromycin works wonders, and particularly if they have chronic bronchitis component instead of emphysema predominant component. If they have chronic bronchitis component, they respond to long-term azithromycin at a dose of, generally we start at a dose of 500 mg twice weekly, and then probably if everything is stable, we can cut down to 600 mg twice weekly or sometimes 250 mg thrice weekly. And there is some evidence for mucolytics that NAC which can potentially reduce the exacerbation, but the evidence is not really robust. So those patients, once we have initiated the treatment, once we initiate treatment, patient is stabilized and it appears like, symptomatically patient CAT score is well within normal limits, MMRC got better, then you please maintain the patient on the same therapy. Unlikely in asthma, the chances of de-escalating from a triple to double or double to single is slightly less. Hope Dr. Bharat will also agree with me. In our practice, once we reach apex, COPD patients de-escalating or decreasing the molecules is a rare phenomenon. And we have examples of certain examples where we have used out-of-box some medications to decrease the amount of dosage of medications and inhaler that we can use. We'll discuss one-to-one basis. And if the initial response to treatment is inadequate, then definitely, we have to check whether the patient is taking proper inhaler therapy and adherence to therapy is good or not, and other comorbid conditions whether we have addressed or not. Like, and when the patient is having predominantly dyspnea or exacerbation as one of the traits, if the patient is having dyspnea and if the patient is getting only LABA or LAMA, then we can step up to LABA plus LAMA, and you can play out with sometimes DPA to MDA, MDA to probably breath actuated MDA, this kind of probably one inhaler may be working him better and the other may not be working for him. Another important thing which we do see in our practice is based on FEV1. Patient may be having a severe airway obstruction. Patient may be having a 40% FEV1. And generally physicians assume that patient may not inhale properly. FEV1 is the exhaled volume, what we are measuring in the 1 second. So they have a pulmonary component, particularly when they have a dyspnea as a chief complaint. So addressing carpulmonary with a small amount of diuretic and then suggesting them to restrict the fluid intake and then salt restriction would do wonders in such cases. But if the patient is having an exacerbation as a chief complaint, then invariably, as of now guideline says, a triple therapy works wonders in these patients. And to control the exacerbations, again, addition of macrolide will play crucial role, particularly if they have a increased put-up production as a symptom. And how to improve the endurance on these patients? Yoga, there is enough evidence practicing pranayama, practicing kapalabhati, practicing yoga postures, they invariably increase their overall muscle strength, thereby their quality of life can be enhanced. And we constantly instruct them to attend a structured rehabilitation program. The adherence to rehabilitation programs are generally poor even in metros. So, but it's our duty to advise them to follow a structured rehab program. Even CIPLA has an online training program where they train almost every day, multiple sessions they take online so that the patient's overall quality of life can be enhanced. And it is very, very important to train them for firstly breathing and diaphragmatic breathing exercises so that they will feel much better because the air trapping hyperinflation component will be addressed with firstly breathing and diaphragmatic breathing so that they will feel much better symptomatically. And treatment of comorbids, it's very, very uncommon to see COPD as an isolated presentation. There may be hypertension, there may be coexistent cardiac issues, there may be osteoporosis, there may be weight loss. Since it is a systemic inflammatory syndrome, there will be huge weight loss because nutritional compromise will be there. So, it can be enhanced. And what are the various things? We know very clearly. So, if the patient gets recurrent exacerbations, the chance of losing him is very high. If a patient every patient from the age of 20. So, what are the various vaccinations? As Dr. Bharat was rightly mentioning, as per the gold guidelines, influenza, pneumococcal and DPT, COVID vaccination and zoster vaccination. These are very, very important. Please make sure, at least from as a physician point of view, we must advise them not, but one word of prescription definitely matters. At least if not in the first visit, in the eventually second or third visit, they will definitely come back, sir, okay. And once they experience like decreased number of infections in the subsequent year following vaccination, they themselves will come and request in the subsequent visit, sir, any vaccinations are pending for me. And maintaining a chart in the first page of OP sheet is very, very important, so that even if it skips mine, then probably if it is in the front page of the book, then we can recognize and then administer the vaccinations. And antioxidants, as I was mentioning, there is not much of robust. Again, we have to take this paper with a pinch of salt. And treating acute exacerbations, inhaled bronchodilators, and oxygen therapy, and target oxygenation is a PO2 of 58 to 59 is good enough. We should not aim to maintain a saturation of 100. A 90 or 88 to 90 of saturation is good enough in most of the patients. And if there is a type 2 failure, early initiation of NIV, and careful, once we are initiating an NIV, make sure that some physician or at least your resident stays with the patient and closely monitor. Within an hour, the guideline says within an hour or two, you have to repeat the ABG and make sure the CO2s are not worsening and patient is not getting comatose. Because a comatose patient or semi-comatose patient is a strong contraindication for NIV. And oral steroids may be 30 to 40 mg once daily. Antibiotics as per the local antibiograms, and bronchodilators, oral theophylline would all work.
ఈరోజు ఐఎంఏ నిజామాబాద్, శ్రీ విష్ణు సూపర్ స్పెషాలిటీ హాస్పిటల్ నిజామాబాద్ వారు సంయుక్తంగా నిర్వహించిన రోడ్ ప్రోగ్రామ్, అంటే రిఫ్లెక్షన్ కోర్స్ ఆన్ అబ్స్ట్రక్టివ్ ఎయిర్వే డిసీజెస్. అంటే మన కాలంలో ఇప్పుడు చూసినట్లయితే ఆస్తమా అండ్ సిఓపిడి అనే జబ్బులు ఊపిరితిత్తులకు సంబంధించిన జబ్బులు. ఈ రెండు జబ్బులు ఎంత ప్రాణాంతకంగా మారుతున్నాయంటే, మన ప్రపంచం మొత్తంలో చూసినట్లయితే ఇప్పుడు ఆస్తమా వారిన మరణిస్తున్న వాళ్ళలో ఎంతమంది ఉన్నారో వాళ్ళలో 46% మంది భారతదేశంలోనే చనిపోతున్నారు. అలాగే సిఓపిడి అనే జబ్బు, ఊపిరితిత్తులకు సంబంధించిన జబ్బు, చాలామందికి ఆ జబ్బు ఏంటో తెలియదని అంటారు. అది స్మోకింగ్ చేసే వాళ్ళలో వచ్చే జబ్బు. ఈ జబ్బు వలన ఇది ప్రపంచంలో మరణాలలో 2వ స్థానంలో ఉంది. అంటే ఆస్తమా అండ్ సిఓపిడి అనే ఈ రెండు పెద్ద జబ్బులు మానవులని ఎంతోమందికి మరణానికి కారణంగా మారుతూ ఉన్నాయి. సో ఇటువంటి జబ్బుల గురించి ఒక అవగాహన సదస్సుని ఈరోజు మనం నిజామాబాద్లో నిర్వహించడం జరిగింది. దీనికి 100 మంది డాక్టర్లు రిజిస్టర్ చేసుకోవడం జరిగింది. ఆల్మోస్ట్ 150 మంది డాక్టర్లు రావడం జరిగింది. ఎంతోమంది సీనియర్ డాక్టర్లు అయినా డాక్టర్ రవీందర్ రెడ్డి సార్ గారు, అలాగే ఐఎంఏ ప్రెసిడెంట్ డాక్టర్ రామచంద్ర సార్ గారు, డాక్టర్ జలగం తిరుపతిరావు గారు ఐఎంఏ సెక్రటరీ, అలాగే డాక్టర్ కవితారెడ్డి మేడం గారు, డాక్టర్ అరవింద్ సార్ గారు, అండ్ డాక్టర్ కరుణాకర్ సార్ గారు, డాక్టర్ వెంకటరమణ సార్ గారు, అలాగే చాలామంది సీనియర్ డాక్టర్ ప్రదీప్ గట్టాని సార్ గారు, అలాగే సీనియర్ డాక్టర్లందరూ కూడా ఈ అవగాహన సదస్సులో వచ్చేసి వారి అనుభవాలని, జబ్బు గురించి, దానికి ఎలా ట్రీట్మెంట్ చేయాలి అన్న విషయాల గురించి చర్చించడం జరిగింది. దీనివల్ల ఇటువంటి జబ్బులనే మనకి ముందు ఈ ప్రపంచంలో, మన దేశంలో, అలాగే మన రాష్ట్రంలో ఈ జబ్బుల బారిన పడే వారి నుంచి ఎలా కాపాడాలి అనే విషయం పైన ఈ అవగాహన సదస్సు అనేది జరగడం జరిగింది. ఈ ప్రోగ్రాంకి నిజామాబాద్, కామారెడ్డి, ఆర్మూర్, నిర్మల్, బోధన్, బైన్సాయ్ లాంటి నగరాల నుంచి సీనియర్ డాక్టర్లు అందరూ వచ్చి పార్టిసిపేట్ చేయడం జరిగింది. దీనివల్ల ఇప్పుడు ఏంటంటే ఈ ఆస్తమా అనే జబ్బు, సిఓపిడి అనే జబ్బు ఎలా తగ్గించాలి, దానివల్ల వచ్చే ప్రాబ్లమ్స్ నుంచి మనం ఎలా కాపాడుకోవాలి, ముఖ్యంగా ఇన్హేలర్ డివైజెస్ ఏవైతే ఉంటాయో వాటి ప్రాముఖ్యత, అవి ఎలా వాడాలి అనే విషయం పైన మనకి ఈ సదస్సు అనేది జరగడం జరిగింది. సో ఎందుకు చాలామంది డాక్టర్లు వచ్చి దీని గురించి యంగ్ డాక్టర్స్, అలాగే సీనియర్ డాక్టర్స్ అందరూ కూడా ఈ సదస్సులో పాల్గొని వారి యొక్క ఎక్స్పీరియన్సెస్ కూడా షేర్ చేయడం జరిగింది. ఈ మంచి ప్రోగ్రామ్ నిజామాబాద్లో జరిగినందుకు చాలా సంతోషంగా ఫీల్ అవుతుంది.